Sir, sorry, sir, there's some small technical issue. We will start in 1 minute, sir.
Sure.
A very good evening to all. It gives me an immense pleasure to welcome you all to the academic webinar on the approach of tropical diseases conducted by the IMA-MSN MMC on behalf of IMA Students Network and Junior Daughter Networks, Tamil Nadu. Today, our esteemed speaker is Dr. Yogesh Sir, Senior Assistant Professor in the Institute of Internal Medicine. Now, I welcome Dr. Gokul, Chairperson IMA-MSN MMC Council, to give the welcome address.
A very good evening, everyone. Is it audible? Sir, Bala sir, is it audible?
Yes, you are audible, Raf.
It's audible. Please proceed.
Very good evening, everyone. I'm Gokul Tanigisan. I am MSN MMC Council Chairperson. So today we are gathered here for a webinar on approach to common tropical diseases. So we are delighted to welcome our distinguished dignitaries, Dr. P. Senguttuvan sir, Dr. Abul Hasan sir, Dr. S. Karthik Prabhu sir, Dr. S. Gauri Shankar sir, Dr. R. Annamalai sir, and Dr. S. Jamuna Rani ma'am, and Dr. V. S. Harigaran sir. Your guidance and leadership continue to inspire us. It gives us immense pleasure to welcome today's presenter, Dr. Yogesh sir, Senior Assistant Professor, Institute of Internal Medicine, Madras Medical College. We are truly grateful to have our senior patrons of College Council, Dr. Prashant IAS sir, Dr. Praveen sir. We welcome our beloved senior who are guiding us in every step to conduct this event to happen, Dr. Somnath Anand sir, Bala Harigaran sir, and a warm welcome to State Council members of IMA-MSN Tamil Nadu and IMA-JDN Tamil Nadu. At the last but not the least, we welcome the participants of webinar who are showing the uncontrolled love towards learning. Thank you. Now I will hand things over to Sanjana.
Thank you, sir. Thank you for your views. Now I'll welcome Dr. Praveen sir to share his views.
So, good evening, sir.
Hey, good evening. Good evening.
Good evening to all the respected senior leaders of IMA-MSN. Sir has been a wonderful person. Whenever we have called sir for any academic session, he has been kind enough to grant us time and clarify our doubts. So I think the topic that we have chosen has really practical significance, especially for the interns who are working right now. Starting from the month of October up to February, you will see cases surging in the hospitals. So I think from my experience, this will be a wonderful, useful session for all the current interns. I'm sure there will be few interns who will be attending this. So even if not, I think the juniors will be able to take forward the message to them. So thank you, sir. Thank you, Bala, Gokul, and Sanjana for the introduction. And over to you guys.
Thank you, sir. Thank you for your views. Now, it's time to introduce Dr. Yogesh, sir, Senior Assistant Professor at the Institute of Internal Medicine, Madras Medical College. He holds an MD in General Medicine and has presented his innovations in medical teaching at national and international forums. With over 17 international publications and several honors, such as Epicon Gold Medal and Best Researcher Award in 2024, Dr. Yogesh is widely recognized for his contributions to the clinical practice and medical education. Now, let's warmly welcome Dr. Yogesh, sir.
Yeah, thank you, Ma. Thank you for your brief intro. So, shall we start, team members?
Yes, sir.
Okay, so without much delay, I'll just start the topic. Yes, can you all see?
Yes, sir.
Slideshow is there?
Yes, sir.
Fine. Okay. So, yeah, warm welcome to all the delegates and participants who are going to listen with me along some maybe 1 hour. So, I'm going to just brief you about how to approach to common tropical infections. Okay. So, they have given a brief introduction about me. So, I'll just go to the topic. So, what we all mean by tropical. So, tropical na enna first. Why we are supposed to know about the tropical infections, especially in this winter season. So, the tropics or tropical regions, they are nothing but our Earth surrounding the equator, and thus they receive the solar energy throughout the year. They remain hot and humid throughout the year, which is ideal for most of the vectors of tropical diseases. Okay, so this is general outline of this tropical diseases. So can you all tell what are the different tropical diseases? Can you just type? Mostly this will be an interactive session, so I request few of you to actively participate. Otherwise, it's going to be just a theory topic. Can you name one or two tropical infections? Yes, dengue, malaria. Then yellow fever, we don't call it as a tropical infection. Tuberculosis is an infectious disease, not a tropical infection. Anyone? Typhoid, cholera, leptospirosis, scrub typhus, chikungunya, lepto, scrub. Okay, fine. Okay, fine. Fine. So, with this small intro, I'll just go into the topic proper. So, tropical infections. So, infections that are unique and prevalent in tropical and subtropical regions. So, what are these tropical infections? One is dengue, second is malaria, third is your leptospirosis, fourth is scrub typhus, which comes under the classification of rickettsial fever, and finally you have the enteric fever. Does influenza or swine flu comes under tropical infection? Can anyone tell? Our swine flu or H1N1, H3N1, all the common flu, will it come under tropical infection? Okay, so it doesn't come under tropical infection, right? So if you just see this graph, you can see that the burden of dengue here, you can see that dark red color. Whole India is fully of dark red color. And you can see that 7.5 to 32 million annual infections are there in India. When you come to the scrub typhus, again, India comes almost 7.5 millions every year. When you come to the burden of malaria, almost all over the southern part of Asia is going to get affected with malaria. So this is what is the burden of dengue, scrub typhus, malaria in our country. Okay. Dengue fever is the most common tropical infection in our part of the country. So this has been done as a systemic review with more than 1,000 of articles which has been combined. So diversity of infections of acute undifferentiated fever in South and Southeast Asia is mostly our dengue fever. Okay. So what I have divided is there are few pictures, there are few case-based scenarios, and I have splitted my topic into syndromic approach to tropical fevers. Okay. So what is this syndromic approach? These can be divided into 5 syndromic categories. One is acute undifferentiated fever. What do you mean by acute undifferentiated fever? We'll just look into the next slides. Second is fever with rash or thrombocytopenia and arthralgia. Third is fever with respiratory distress, fever with encephalopathy, and fever with multi-organ dysfunction. Okay, so this is called as syndromic approach to tropical fevers. So, undifferentiated fever, few examples are malaria, scrub typhus, leptospirosis, typhoid, dengue, and other common viral infections. Next, coming to the fever with rash. So, what are the fever with rash? First is our dengue fever. Second is rickettsial fever. Third is malaria. Fourth is leptospirosis. 5, we often tend to miss these 2 viral infections. One is measles and the other is rubella. Okay. And the third entity is fever with ARDS. ARDS is nothing but acute respiratory distress syndrome. So, after maybe 5 or 6 days of fever, within a week, they develop acute onset of breathlessness. That we call it as acute respiratory distress syndrome. In that, the most common thing what we have is the scrub typhus, scrub ARDS. Second is your malaria and influenza, including H1N1. All those things doesn't come under the tropical infections. Okay, this is general overview of fever with ARDS. The next is febrile encephalopathy, encephalitis, or meningitis. Here we have our scrub typhus, cerebral malaria, and typhoid encephalopathy, otherwise called as typhoid psychosis. And the final is our fever with MODS. Fever with multi-organ dysfunction syndrome, we have quite a lot of bacterial as well as viral infection. The most common will be bacterial sepsis. Second will be falciparum malaria. Third is leptospirosis, followed by scrub typhus. Finally, even dengue can precipitate multi-organ dysfunction syndrome. Other things are quite rare, following your hepatitis A or hepatitis E, fulminant hepatic failure, hantavirus, and other very, very rare viral infections. So this is general approach of fever with syndromic approach. Okay. So what are the important factors that to be considered whenever we look into syndromic approach? Number 1 is season. Now we are like in the winter season. So ongoing epidemics are our dengue, leptospirosis, malaria, that is quite common in June to August. The second important things we need to consider is travel history, especially when they have contact with vegetations. So what are the diseases that can be spreading through our vegetations? So that is our scrub typhus, which is nothing but our rickettsial family. The second is travel to endemic locations, nothing but our malaria, which is especially to the southeast part of your Africa. The third important thing we need to consider is socio-economic factors, that is crowded living or insect breeding sites at home, especially all the vector-borne diseases, which includes your malaria. And then comprehensive histories like recent travel or any other food intake which is contaminated, or especially people working in village side. So you need to ask whether they have a agricultural farm where they used to harvest and they use our barefoot. Finally, localization to the systemic sites like your hepatomegaly or splenomegaly or lymphadenopathies. Okay, so these are all the factors that needs to be considered when you look into syndromic approach. First, coming to the undifferentiated fever. So what do you mean by undifferentiated fever? When there are no systemic localizing features, that is your signs and symptoms associated with fever, you are not able to find out any localizing features. So what are the common conditions? This we have already seen. So in malaria, you have paroxysm of fever, chills and sweats. Scrub typhus, you have headache, myalgia, painless eschar. Third is leptospirosis. You can have conjunctival suffusion. Your conjunctiva becomes very red and it is chemotic and it is dilated. All the blood vessels are dilated. Next, coming to the enteric fever, you have the relative bradycardia, which is called as the Faget sign, F-A-G-E-T, Faget sign, okay? And you have diarrhea or hepatosplenomegaly. Then coming to our dengue fever. So dengue fever, you have the retroorbital pain, headache, and arthralgia. H1N1 and other common viral illnesses which are more common at present. You have less than 1 week of fever, myalgias, coryza, and cough. You have excessive productive cough. Suddenly, within 3 days or 4 days, they have a wheeze or they have more productive cough. That is called as coryza. Okay. So these are all common examples of acute undifferentiated fever. Next, coming with fever with rash. So almost all these infections can have rashes. So dengue can have maculopapular rash. Scrub typhus, already we saw painless eschar. Meningococcal infection, that is meningococcemia. Enteric fever, you have rose spots. Herpes simplex virus, you have vesicular rash, and chikungunya, you have maculopapular rash. So any fever, day 1, day 2, day 3, onset of fever, you get a rash, you have to consider all these infections. So can you all identify this second one? We'll come into the first and third picture later. What is this? Can you tell this in which disease you get this kind of image? Yes, lepto, scrub typhus, eschar, scrub typhus. Okay. Okay. Almost everyone says that it is an eschar. So how to identify this eschar? So you can see that there is a central scab which is black in color. Surrounding there is an tissue area where it is healing. Okay. So this is an ulcer where these insects or these mites enter into the skin, and there they produces this ulcer, and the ulcer heals forming a scab. So this is called as an eschar. Okay. So this eschar has to be searched in all the hidden areas. So number one hidden area is your axilla. Second, in females, below the breast. Third, groin area. Fourth is in the back of the abdomen. So these areas has to be thoroughly searched for this eschar. Many a times we tend to miss the eschar in the early days. Maybe this will take 4 to 5 days to develop. Okay, so this is an eschar. Next, coming with fever with encephalopathy. So encephalopathy meaning altered sensorium. Patient will go for altered sensorium within 3 to 4 days onset of fever. So what comes first in our mind? First is our cerebral malaria. Especially we all belong to the endemic area of malaria. So malaria on blood smear, HRP antigen, all these things will diagnose that this is a cerebral malaria. Next, coming to the meningitis. Meningitis, you have neck rigidity. The CSF findings will show either pleocytosis or organism. Especially you can see the gram stains. Third is encephalitis, most common, that is herpes simplex virus. So any patient coming with fever with acute onset of seizure, you have to consider herpes simplex virus followed by Japanese encephalitis. Okay. And other infections, that is your tuberculous meningitis, enteric fever, dengue fever, brucellosis, leptospirosis, all these are other infections which can also produce encephalopathy following fever. But the most common things is first is malaria, second is your meningitis, third is your encephalitis. Okay. Next, coming to the fever with acute respiratory distress syndrome. So in this we have scrub typhus. So scrub typhus, we just saw the eschar. So within 7 days of fever, they go in for acute onset of dyspnea. So you need to consider scrub typhus. Second is falciparum malaria. You have especially 48 hours fever, 72 hours fever. You call it as malarial tertian or malarial quartan, depending on the hours of incubation period. So third one is your influenza, H1N1. Again, less than 1 week of fever, myalgia, coryza, cough. You diagnose it as possible influenza virus. Then comes your leptospirosis. So you have this abdomen pain, conjunctival suffusion. Again and again I'm repeating this. Conjunctival suffusion. If you see the conjunctiva, it will be mostly all the blood vessels will be dilated and red in color. So that favors one of the sign of leptospirosis. And you have biphasic illness, meaning you will be having fever for 3 days. Another 2 days, there will be afebrile phase, followed by another febrile phase. So, fever, afebrile, fever. That is called as the biphasic illness. And severe community acquired pneumonia, you have the cough, pleuritic type of chest pain, fever, leukocytosis, all these things. So this is nothing but our fever with ARDS. Okay. And finally, we have the fever with MODS. So MODS meaning multi-organ dysfunction syndrome. When you have two or more systems that is getting damaged, we call it as multi-organ dysfunction syndrome. So simple example is liver failure and renal failure. So what are the conditions you get these two organs getting involved? One is your bacterial sepsis. Okay. So any kind of infection with low immunity progression into sepsis. They have liver and renal failure. Second is our falciparum malaria. So we'll see why falciparum malaria going for MODS, leptospirosis going for MODS in the subsequent slides. So all these things has to be considered when you have MODS. So falciparum malaria, leptospirosis, dengue fever, and finally your hepatitis A or hepatitis E infection going in for fulminant hepatic failure. Okay, fine. So in this one picture, you can see that when you have the focus of infection which has been identified, you go in for a specific treatment. So for example, pneumonia, pyelonephritis, biliary source of infection or cellulitis, you start empirical treatment as per the source. But if you are not able to identify any source of infection, you have to assess the clinical syndrome, whatever we have discussed till now. Okay. So consider the risk factors, the geographic area, the season, as well as the associated symptoms. So here you have the fever with rash, fever with jaundice, fever with ARDS, fever with MODS. Then when you have identified the syndromic approach, then you do the corresponding infection profile. So for example, if you think of malaria or dengue or typhoid, you go for specific test, like you have the rapid diagnostic test, you have malaria card test, you have MPQBC, and you have dengue NS1 antigen IgM test. Okay. So this is a general outline of how to approach to a patient with tropical infection or fever of unknown. Now, this one slide will tell you common tropical illness which has specific organ involvement. Okay. So for example, first we will consider the malaria. So malaria, we just now saw that it can go for encephalopathy. So CNS involvement might be there. Lung involvement, yes. If it is going to be severe malaria, there is going to be ARDS. Liver involvement, yes, definitely hepatomegaly, because of the hypnozoite multiplication is going to happen in the liver. If you are going to have kidney involvement, that is renal failure, that is specifically due to cerebral malaria, which is nothing but your hemolysis. So you can have a renal involvement also. Coming to the platelet. So platelet, you have thrombocytopenia, and the total leukocyte count may or may not be elevated in the final stage. Okay. So these are all features of malaria. Then coming to the dengue. So dengue, we saw that fever with encephalitis, one of the syndromic approach will be dengue. Lungs, you have pleural effusion. Liver, definitely your SGOT and SGPT enzymes will get elevated. Kidney, final stage, because of shock, it goes for renal failure. Platelet count, yes, definitely thrombocytopenia is going to be there. Total count, definitely there is a leukocytopenia. Okay. Coming to the leptospirosis. CNS involvement, yes, it is one of the differential diagnosis of your encephalitis syndrome. Lung involvement, yes, definitely ARDS, or it can go for even pleural effusion. Liver involvement, yes, definitely there is going to be a liver failure in severe leptospirosis. Renal involvement, definitely the lung, the liver, the kidney, all these vital organs get damaged in severe leptospirosis. Platelet count, yes, low platelet count. Here it depends on the severity. If it is going to be just a mild there is total count elevation. If there is going to be severe leptospirosis, because of the sepsis component, you will have leukocytopenia. Then comes your rickettsial infection. We just now saw the scrub typhus. Scrub typhus encephalitis. Yes, CNS involvement is going to be there. Lung involvement, if it is going to be scrub typhus, definitely ARDS is going to happen. But otherwise, rickettsial infection commonly it doesn't cause of any problem with lung. Liver and kidney, yes, damage. Leukocytosis, yes, leukocytosis is going to be there. Thrombocytopenia, yes, definitely thrombocytopenia is going to be there. Finally, your typhoid. Typhoid, yes, typhoid psychosis or typhoid encephalopathy. Lung involvement, quite rare. Liver involvement, definitely your bilirubin is going to get elevated. Renal damage, so quite rare. Except the liver part, typhoid will not have much of symptoms. Thrombocytopenia, yes, mild thrombocytopenia is going to be there. Total leukocyte count, it depends on whether mild or severe. Again, mild, total count is going to get elevated. Severe typhoid, the total count is going to get decreased. Okay. So this one slide will tell you which type of tropical illness is going to involve which organ, and you can order the blood test accordingly based on this clinical profile. Okay. Fine. So from now on, it's going to be an interactive session. So case scenario, this is going to be a 32-year-old male farmer presented to the emergency department with fever, chills, myalgia for 5 days. He also complains of headache, conjunctival redness, and dark colored urine since yesterday. Vitals 90/60, pulse rate is 104. Patient is having febrile, mild icterus, all other systems fine. Hypochondrial, right-sided hypochondrial tenderness is there. When you see the total count, it is 13,800. Platelet, low platelet, 85,000. SGOT, SGPT, mild rise is there. Creatinine, 2.6, there is renal failure. So what are your differential diagnosis? What are the other relevant investigation you want to do? How will you manage this case? So just one point quickly. Yes, lepto, anything. It's not like always you have to think of only lepto. You have to give differential diagnosis. Falciparum malaria. Okay. Falciparum malaria. Why do you say so? Falciparum malaria. Why do you think that this could be a falciparum malaria? Hepatitis la it doesn't go for renal failure, so that is against, and there won't be total count like bacterial infection. So here we have leukocytosis. Dengue again, you have a total count which is 13,800. Low platelet renal involvement. Okay, fine, partially you're right. There are certain clues in the, you can see there is, this is a farmer, okay, and he is coming with fever, chills, myalgia. See, fever, chills, myalgia is going to be common symptoms of all kinds of tropical illness. Okay, so don't go with chills இருந்தா அது வந்து மலேரியா அப்படி கிடையவே கிடையாது. Please erase from your brain. Chills is one of the symptom of high grade fever, that's all. Chills இருந்தா அது வந்து மலேரியா கிடையாது. Okay, so please remember this. The second important thing is conjunctival redness that can even be in dengue. But here there is a clue given is dark colored urine since yesterday. So 5 days la வந்து 2 days he is having like dark colored urine. It might be a hematuria. We don't know unless we do a urine routine. But when you see the pulse and BP, he is going for shock. Can you all see that 90/60, which is your shock? Hemoglobin, though there is dark colored urine, hemoglobin is 13.2, but the total count you can see here is 13,800, which is in favor of leukocytosis. And SGOT, SGPT is mild raised and renal failure is 2.6. So differential diagnosis, what I could offer here is first come leptospirosis, second come someone told malaria. Yes, there could be even a malarial infection. The only thing which is not relevant here is the total count. Okay, fine. So here we have a case of leptospirosis, right? Leptospirosis. So I'll just tell one or two points from each slide alone. You have, this is the most important, zoonotic disease. What do you mean by zoonotic disease? Which gets transmitted through the diseases of animals. Okay. It has mild to fulminant fatal diseases. You have 64 leptospira species. In that, pathogenic is 17, and rats are the most important reservoir. So here you have to remember three R. One is rat, second is rainfall, third is rice paddy field. So here we have the farmer with maybe rat, rainfall can be there in the season, third is rice paddy fields. So here we have the important reservoir as rat. So this is a, you can see that this is a leptospirosis with spiral shaped bacterial organism, and you can see that the endoflagellum is there, and anti-clockwise rotation is going to be there because of the endoflagellum. So this can be seen only through a dark ground microscopy. So here in this, you can see that the mild disease can have arthralgia, myalgia, fever. So this combination of symptoms will be there in all the fever: headache, vomiting, malaise, myalgia, fever. இது எல்லா ஃபீவர்லயும் இருக்கும். Okay. So with this mild disease, you cannot diagnose this as a leptospirosis. Only when it goes for severe diseases like liver dysfunction is there, renal dysfunction is there, or it's going for ARDS or myocarditis, then you suspect this is a severe disease of leptospirosis. And this is due to the contamination of water and soil with leptospirosis. And leptospirosis is a diseases of wild animals. Okay. And it gets transmitted through barefoots. So here what I could tell you as important point from this slide is, always teach your neighbors, teach your relatives, or whoever is going in barefoot, please tell them that this disease can be entering in our body through abraded skin, especially through the barefoot. So please ask them to wear shoes or sandals whenever they go out. Okay. Fine. Anyone? Conjunctival suffusion is in only severe or mild. It can be there even in mild, but mostly severe phase that I'm going to come. Leptospiremic phase. Adula vandu you have this conjunctival suffusion very well seen. Okay. So mild infection irukuman keta, yes, mild irukum. Fine. So you have incubation period of 2 to 30 days. This has a longest incubation period. Just note it down, 2 to 30 days. So we have leptospiremic phase, high motile tissue barrier, it enters, disseminated hematogenously to all organs. Immune phase, where the antibodies coincide with the disappearance of leptospirosis from the blood. And severe disease, you have this acute tubular damage because of interstitial nephritis, hepatocellular necrosis, and bile leakage. So these two constitutes the liver and the renal failure. And finally, you have disseminated intravascular coagulation. So can someone tell what is the triad of Weil's disease from this slide? Already two are there. Weil's disease, W-E-I-L, Weil disease. Yes. Can you tell? So here we have the Weil's disease or Weil's syndrome. So in severe leptospirosis, we have jaundice, that is liver failure, acute kidney injury, and finally you have hemorrhage anywhere in the body. So hemorrhage in the lungs, hemorrhage in the brain, hemorrhage in the GI system. This we call it as a triad of Weil's disease, which is nothing but your severe leptospirosis. Okay. Fine. So someone asked whether mild leptospirosis will have that is your conjunctival suffusion. Yes, even mild will have conjunctival suffusion as one of the symptom. Please don't go with one or two symptoms for diagnosing a tropical infection. That is completely wrong. Okay. So you have to go for a syndromic approach, whatever we have discussed. So conjunctival suffusion mattu irundhaduna leptospirosis? No, never. You have to have all these symptoms. Another important thing I want to tell you from this slide is muscle cramp, muscle pain, especially in the calf muscle or in the back muscle, it favors leptospirosis. Okay, fine. This is one addition point I want to tell. So conjunctival suffusion, muscle cramps, muscle pain, especially calf muscle, you will have leptospirosis as one of the differential diagnosis. Fine. So the important test someone told, we have the MAT test, MSAT test, microscopic agglutination test, macroscopic agglutination test. So in that we have this MAT test, which is gold standard test. Okay. So all these are like leptospirosis, from which day to which day it might be there in our blood sample. Okay. Fine. So basic investigation, as we all know that one slide I told regarding the CBC, renal function, liver function, you do that and find out. CRP and procalcitonin are important markers of bacterial sepsis. So procalcitonin is one important marker of bacterial sepsis. If you think that this is a viral fever, procalcitonin will not get elevated. Procalcitonin normal value is less than 0.5. When you have any fever more than 0.5 or 1, then you think of sepsis because of bacterial infection. So here CRP and procalcitonin will get elevated, and the microscopic agglutination test is the gold standard test for this disease. So 1 is to 200 to 1 is to 800 will be the important lab investigation. Treatment for mild leptospirosis, doxycycline 100 milligram BD or amoxicillin or ampicillin as IV can be tried for mild leptospirosis. For severe leptospirosis, previously we were using penicillin 1.5 million units IV or IM Q6 hourly. But due to the Jarus hexamer reaction and many people getting allergy to penicillin, the now current drug of choice will be ceftriaxone 2 gram per day as IV. Other injections are cefotaxime and doxycycline. For chemoprophylaxis, where people are coming from infected area, doxycycline 200 milligram once a week can be taken till the patient goes back to the original place. Or azithromycin can be tried if the patient is pregnant. Okay, because doxycycline cannot be given during pregnancy. So azithromycin is the alternative choice. Okay. So any doubt for leptospirosis? This is how we manage a case of leptospirosis. Mild, severe. Mild, doxycycline or amoxicillin. Severe, you go for direct IV antibiotics. Okay. The most preferred antibiotics will be ceftriaxone 2 gram IV OD for 7 to 10 days. Okay. Fine. So prevention, again, you wear a footwear, proper eyewear and other protective equipments. Target the rodent control. Vaccines for agricultural and companion animals should be encouraged. Fine. Can we go to the next case? Yes, guys. Please comment on total count. Total count will always be elevated in mild, but when it goes for sepsis, it goes down. Always remember, whenever you have mild bacterial infection, the total count is going to get raised because of the immunity. Once, when it is full-blown sepsis, then the total count is going to get reduced because of bone marrow suppression, right? So initial stages, you have leukocytosis. The severe stages, you have leukopenia. Fine. Okay. Now you read this case scenario. 28-year-old male, rural area, construction worker, high-grade fever with chills and rigor for 4 days. Again, our headache, body pain is going to come. Vomiting, again, it has come. Now, HOPI, you have significant histories. Fever intermittent, associated with chills, sweating, and malaise. Headache is there. There is no previous history, like similar past history. It is not significant. Personal history, non-alcoholic, non-smoker. Okay. General examination, high grade fever, the pulse rate is 108, pallor is present, icterus is present, but lymphadenopathy is absent, edema is absent. Okay. So systemic examination, you can see liver palpable 2 centimeter below the right costal margin, which is soft, SOFT, soft and tender. Spleen is also palpable 3 centimeter below the left costal margin. Okay. So have you all seen this history? So 28-year-old male with intermittent fever, chills, sweating, malaise. On examination, he has pallor, he has icterus, no lymphadenopathy, liver is palpable, it is soft, spleen is palpable 3 centimeter below the left costal margin. So I want few of you to answer this case scenario. Dengue, malaria, malaria. Anything else? Malaria. So everybody wants malaria. Okay. Someone told dengue, no? I want them to answer why did they think of dengue fever? Your answer might be right, but I want to know why you thought of dengue fever. I saw 2 or 3 people commenting about dengue fever. Painful hepatomegaly. Okay.
Oh my God.
Then anything else? With that single
Spontaneous
sign,
fever, sir.
you cannot diagnose it as dengue fever. Okay, that is what I'm trying to tell. Please don't go with 1 or 2 clinical signs in every patient. You have to see the patient as a whole. Okay, so here, this possible differential diagnosis. See, one thing I want to tell medicine, you don't have a single diagnosis. You always tell differential diagnosis. In that preference of order, in this case, malaria is to be suspected. Then comes why painful hepatomegaly. Painful hepatomegaly, here you have liver palpable தான் சொல்லியிருக்க mild tenderness இருக்கும். ஏன் painful அப்படின்னா liver is going to get enlarged because of all the malarial parasite which gets multiplied inside your red blood cells. So in that we have pre-erythrocyte stage, erythrocyte stage, hypnozoid stage, all those things happens, making your liver mild, bigger in size, but it is still soft. Okay. So you have mild hepatomegaly below your right costal margin. Okay. It will not be that much of painful. It's just tenderness because of the stretch of the capsule. Okay. Fine. Okay. So this is a malaria. Fine. So malaria, I won't go to all these details. We have 5 species. If anyone doesn't know the 5th species, it is primarily a zoonotic infection of the Southeast Asia causing severe malaria. It is called as Neolesi. Okay. And falciparum, most common. Vivax, next common. Malaria and ovale is less common. Okay. So whenever you think of fever, pallor, jaundice, you need to think of falciparum malaria. Okay. Because that goes into the stage called as severe malaria or complicated malaria. And female Anopheles mosquito is going to be the important vector of this disease. Right. Fine. So someone was asking me about why there is a liver enlargement. So you can see all these stages is going to happen in your liver. So whenever this happens inside your liver, the liver மேல இருக்கிறது வந்து glycan capsule. This capsule is going to get stretched because of mild enlargement of the liver. Okay. I'm not going into the detail of all these things because this is your job to read all these things. My job is only to discuss about the syndromic approach. So I'm going into the incubation period. So falciparum 9 to 14 days. So think of this. Leptospirosis is up to 30 days. Here we have half 9 to 14 days, or in Vivax you have 12 to 18 days. Why this incubation period is important? Because you need to ask a proper history with the patient. So whenever patient tells that this is going to be like 5th day of fever, then you think of these kind of diseases, right? That is why the incubation period is very important. So now we have classical paroxysms of this disease. So cold stage, shivering, chills. So ஒரு மணி நேரத்துக்கு வட 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 வடன்னு ஆடிக்கிட்டே இருப்பாங்க, chills with shivering. Then comes the hot stage, high grade fever with headache and vomiting. Finally, sweating stage with sweating profusely and exhaustion. இது எல்லாத்துலயுமே you can see that headache, myalgia, arthralgia, malaise, nausea, vomiting, all these things is going to come. This is going to be a common entity for all the disease. Here, classically, we have cold stage, hot stage, and sweating stage. When do you call it as severe or complicated malaria? Take this important slide. Any one of the following indicates severe malaria. Most often it is Plasmodium falciparum. Why I am stretching this falciparum is you have falciparum treatment separate, Plasmodium vivax separate. Okay. So if you give wrong medicines, that is not going to improve the condition. Okay. So that is why I'm highlighting here. Severe malaria indicates most often it is falciparum malaria. Okay. So that we call it as cerebral malaria. The important differential diagnosis we have already seen in the syndromic approach, altered sensorium with seizure or even coma. ஸோ கோமால ஒரு பேஷண்ட் ஃபீவரோட வராங்க, சீஷரோட வராங்க அப்படின்னா one of the differential diagnosis should be cerebral malaria. Okay. Second is you have severe anemia because of hemolysis. Hematocrit is going to be less than 20%. Or if there is a renal failure or oliguria, creatinine more than 3 milligram per deciliter, then that is one important finding. Jaundice, total bilirubin is more than 3 milligram per deciliter with elevated SGOT, SGPT. Then comes your ARDS or pulmonary edema, non-cardiogenic pulmonary edema. Then severe metabolic acidosis. Please do a ABG for this patient. You can see metabolic acidosis. Hypoglycemia. The blood glucose level is going to be less than 60, maybe even less than 40 also. The patient is going to go in for circulatory collapse or shock. Then comes spontaneous bleeding because of DIC. And hyperparasitemia, it's very difficult to find out. And repeated convulsions. In the idle, if you have any one of the following with all these cold stage, hot stage, sweating stage previously, then you call it as severe malaria or complicated malaria. Okay. Finally, you have this relapsing malaria or chronic malaria. In that, you need to highlight is Plasmodium vivax and ovale due to the dormant hypnozoid stage in the liver. So always you need to give a hypnozoid eradicating drug. So can you tell what is the hypnozoid eradicating drug that has to be given maybe for 14 days? Yes. Fine. Primaquine. Okay, fine. We'll proceed. Very good. Okay. So all these things I'm not going into the depth. இங்கே வந்து poor prognosis for falciparum malaria is marked agitation. Patient will be throwing seizure, hyperventilation with respiratory distress, low core body temperature. Patient will go for below normal temperature. That is hypothermia, bleeding, deep coma, repeated convulsions, anuria, shock. When you have all these clinical symptoms, then the prognosis is very poor for this kind of disease, especially your falciparum malaria. When you see the eye findings, you can see retinal whitening is present, where there are changes in the area of retina in patients with cerebral malaria. Okay. And white-centered hemorrhages. Especially when you see the fundus in cerebral malaria, you can see the hemorrhages. Okay. Hemorrhages with white-centered. You can see the white-centered with hemorrhages. So these are all classic findings of fundus changes in retina when you have malaria. Okay. Cerebral malaria. So this is a 2-year-old boy with malaria and retinopathy. Here you can see that there is going to be effacement of the basal cisterns and the fourth ventricle. Here there is complete loss of sulcal markings in the cerebrum. So can you see anywhere the sulcus markings? Nowhere there is sulci and gyri. So this indicates that this is a typical case of cerebral malaria with retinopathy, right? So these are all like thin films of different varieties of your plasmodium. So all these are like microbiology, banana shaped, round shaped, sickle shaped, all those things. This is like typically a pathology, right? So I'll go to the direct treatment part. So when you have uncomplicated malaria, especially when you have Plasmodium vivax, chloroquine 10 milligram followed by 5 milligram at 12, 24 and 36 hours. This is the standard regimen. Next slide also I will try to explain. So falciparum malaria அப்படின்னு diagnose பண்ணிட்டோம் அப்படின்னா directly go for artesunate, right? directly go for artesunate if you think of falciparum malaria. If you think of Plasmodium vivax, then you directly go for chloroquine. Okay. Black water fever is the severe plasmodium. Yes. Black water fever is another name for cerebral malaria. Retinopathy is due to the disease per se. Chloroquine induced வந்து அது 3 days 4 daysக்கு மேல எடுத்தாதான் you can have all those retinal bullous lesion or bullous what do you call as I am maculopathy or retinal bullous lesions that will be seen after 2 or 3 days of taking chloroquine, not on initial day 1 itself. Okay. Fine. Any other questions? Right. So next slide I will explain you. So this is another important slide. Here, when you have uncomplicated malaria, you have to start for Plasmodium vivax, the previous slide dose. Chloroquine 10 milligram stat followed by 5 milligram per kg at 12, 24 and 36 hours. Okay. Next, when you have severe malaria, the second point here, intravenous artesunate is the preferred treatment. Okay. IV artesunate should not be withheld in pregnant women with severe malaria. Please note this point. IV artesunate should not be withheld. So, pregnant women you can give if you suspect this is going to be a severe malaria, right? So, next coming to the chemoprophylaxis. So, chloroquine 300 milligram base orally once per week is recommended throughout the pregnancy. So, interns, please note down. If you suspect Plasmodium vivax or the thin smear, thick smear is showing Plasmodium vivax positivity, then chloroquine 300 milligram orally once a week is recommended throughout the pregnancy. And after delivery, if the mother is not having any kind of G6PD, then primaquine can be used depending on the breastfeeding status. Or you can use clindamycin also. Fine. Right. So any doubts in this one? You can just have a picture that is photocopy of this one. Severe falciparum malaria, last 3 lines. Artesunate 2.4 milligram per kg stat followed by 2.4 milligram per kg at 12 and 24 hours. So this is the general rules of severe falciparum malaria, right? For vivax, you start chloroquine. For radical treatment of Plasmodium vivax, you can start with, you can see here, primaquine should be given, that is 0.75 milligram per kg. Okay, so that has to be given, right? So any doubt? We'll go to the next case scenario. Shall I proceed? Or is it boring? Okay, bullseye maculopathy, right? Accepted. Can we move on to the next case scenario? Yes, no? Okay, fine. So case scenario 3. 24-year-old male presents with 7-day of history of gradually rising high-grade fever, headache and fatigue. He reports abdominal discomfort, poor appetite and initial constipation followed by loose stools. He drank unboiled water from roadside vendor a week prior. On the 6th day of illness, he noticed faint rose color spot on his lower chest and abdomen. He denies cough or any urinary symptom. Blood test reveals leukopenia and elevated ESR. Vidal test was done and it shows significant titers and blood cultures were sent. Based on clinical presentation, history of exposure, characteristic rash and supportive lab, a diagnosis of typhoid fever is considered. Okay, so this is a clear-cut case of typhoid. But what is my question in this? Now he is entering the second phase of illness, right? Second phase of illness. What complication he can develop once he is left untreated? What are the complications? So much time you were listening with the lab investigations, the syndromic approach. So just tell me, what are the important complications if the patient is left untreated? Very good. Intestinal perforation. Yes, exactly. Right. So intestinal perforation has to be considered. So here also the patient is complaining of abdominal discomfort, but not abdomen pain or constipation or obstipation, because he is followed the loose stools part at present. So if you suspect this kind of history and if it is getting untreated, the patient will present to you with severe abdomen pain, which might be an intestinal perforation because of typhoid fever. Okay, fine. As we all know, this is an enteric fever. This is a food and waterborne infection, and infected person can pass the bacteria through their body via the stools, or less commonly through the urine, and contaminated water sources may be infecting the healthy individuals. Okay. So here someone has messaged severe anemia due to hemorrhage, intestinal hemorrhage. Okay, yes, accepted. Fine. So all these are microbiological aspect. I'm not going to touch all these things. So here ingested contaminated food, it enters. It is taken up by the macrophage. It enters the lymph nodes. It multiplies inside the intestinal lymph nodes. Then it follows diarrhea. Diarrhea is going to start bloodstream infection. That is your bacteremia phase. That is the onset of typhoid fever. And finally, bacteria invade gallbladder, biliary system, lymphatic tissue of the bowel and multiply high in number, then pass into the intestinal tract, that is your stools. Okay, so this is the pathophysiology of your typhoid fever. It's just a reticuloendothelial system, how it gets activated when you're exposed to typhoid. Now, coming to the clinical features, right? So here you have slow rising step ladder pattern of fever, and then abdomen pain. Again, you have mild hepatomegaly, malaise, headache, constipation. Final thing here, you identify relative bradycardia. So what do you mean by that relative bradycardia? Whenever you have fever of more than 1 degree Fahrenheit, you will have raise of your pulse rate and heart rate of 10 beats per minute. For example, if it is going to be 100 degree Fahrenheit, your pulse rate is going to be plus or minus 90 to 100. Okay. So every 1 degree Fahrenheit raise, your pulse rate gets elevated by 10 beats per minute. Right. So this is a general rule. In this patient, you have relative bradycardia, and that sign is called as Faget sign. F-A-G-E-T, Faget sign. Okay. Fine. Second week, you can see all the signs and symptoms progressing. End of second week, if it is not treated, then the patient goes for typhoid delirium or typhoid psychosis. If left untreated, they may die also. Okay, the second week is the most dangerous week of typhoid. Here you can see the rose spots, the rash of the enteric fever due to Salmonella typhi or paratyphi. All these are rose spots, right? Fine. Third stage, in the third week, you can see apathy, confusion, or psychosis, and high risk 5 to 10 percentage of hemorrhage. That is your intestinal hemorrhage and perforation leading on to death. Okay. And final fourth week is the recovery phase, where some survivors may become asymptomatic carriers also, and they have the potential to transmit bacteria through their stools. Okay, so this is the normal step ladder pattern of fever. So in the morning, you can see there is a high grade. When it goes in the evening, little lower. The next day morning, again high grade. Next, and the same day evening, low grade. And it keeps on going like a step ladder fever. Okay, so this is the typical fever pattern of step ladder. Complications we have already seen. Myocarditis and nephritis are the most important complications of this toxic phenomenon. Extraintestinal manifestations, mostly 30 to 35 percentage, the central nervous system gets affected. Because of the central nervous system, you can have encephalopathy, cerebral edema, and meningitis. All these are differential diagnosis of your fever with encephalitis. So always think fever with encephalitis, typhoid can also be one of the important system. And all these are other very less common symptoms, your cardiovascular, pulmonary, musculoskeletal, all these are like little less common, but this can also involve all the organs. So you can see the intestinal perforation and air under diaphragm. You can see the X-ray. See the air under the diaphragm. You can see very clearly the air. Okay, so this is very well seen in the abdomen erect X-ray. Investigation, as we all know, it is going to be the CBC, RFT, LFT. Eosinophenia is going to be characteristic. So tomorrow when you go to your wards, please see when it is going to be in the second week of your incubation period. Eosinophenia is one important characteristic feature of typhoid fever. Always blood culture is the investigation of choice in the first week, because first week you identify 90% of the cases gets detected in the blood culture, and minimum of 10 ml has to be collected for blood culture. Fine. Second week you are going to use your antibody. In this slide is being written as stool culture in the second week. That's wrong. You have normal BASU as one of the important mnemonic. B for blood culture. Okay. A for antibody test. Okay. I'll just write here. BASU. Blood culture in the first week that we saw. Antibody in the second week. Antibody test is your Vidal test. Stool culture in the third week. Urine culture in the fourth week. Okay. In this slide is wrong. Okay, next. Vidal, fine. So role of Vidal, you can easily detect. You have the slide agglutination and the tube test. Treatment, preferred antibiotic of choice is going to be ceftriaxone. Again, which disease we saw the ceftriaxone as one of the important antibiotic of choice? Can you tell? Just now we saw antibiotic of choice. Yes, leptospirosis, 2 gram IV OD. Very good. So here also we have ceftriaxone 2 gram IV OD, 7 to 10 days as the empirical treatment of choice. Oral step down after defervescence. That is, you treat the patient as OPD basis. Azithromycin 1 gram on day 1 followed by 500 milligram once daily for 6 days is the treatment of choice. Very rarely we give ciprofloxacin because we have resistance for this fluoroquinolones nowadays. Very extensive drug resistant typhoid fever, you go for carbapenems. That is high end antibiotic. Okay, fine. So this is a Harrison picture. You can just take a picture. You can just go through it later on. Okay, fine. So antibiotic resistance, you call it as MDR typhoid. So nowadays, like in and out, we use all these ampicillin, amoxicillin, all those cotrimoxazole. So nowadays, high levels of resistance has been noted. So resistance to ampicillin, chloramphenicol, cotrimoxazole, and third generation cephalosporins, you call it as XDR. And azithromycin is sensitive in most of the cases, but nowadays, emerging resistance is being reported because of overuse of azithromycin for common sore throat. Okay, so please don't use azithromycin on your own over the counter basis. So please advise your parents or neighbors that please do not take azithromycin, because this is one important drug of choice for typhoid fever. Okay. Carrier, again, you all remember this typhoid Mary, and carrier state is an independent risk factor for gallbladder carcinoma also. So more than 12 weeks, stools or urine, it is excreted, then you call it as a carrier. Fine. Prevention, again, food and water contamination, washing hands, and proper sanitation. These are all the preventive aspects. And vaccination, you have this oral live attenuated TY21A vaccine. Okay. And you have this polysaccharide subunit vaccine VI as injection form. Okay. So this is going to be the final case. So case scenario 4, Arun Kumar, 28 years, male, office worker, urban Chennai. Date of admission is 10th October. And high grade fever for 5 days, headache and retroorbital pain for 4 days, generalized body ache and joint pain for 4 days. So history of presenting illness, he had a high grade of fever, continuous, but not associated with chills or rigor. There is a severe headache. You can see the frontal headache behind the eyes, especially we call it as retroorbital pain. And myalgia and arthralgia, especially in the knees and back, that is called as breakbone fever. But there is no cough, no sore throat, no dysuria, and, no loose stools. On day 5, the patient noticed gum bleeding and small red spots on the legs. Okay, so what could be the differential diagnosis? All now again telling dengue, 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 because dengue is the left out part. Okay, so here you can have meningococcemia also as one of the important differential diagnosis. Please remember, this will also present same typical features, but except for the breakbone fever, all other features can be there even in bacterial meningococcemia also. Okay, so always remember this. Fine. So dengue, again, it is transmitted through the what mosquitoes? Aedes aegypti mosquitoes. Okay. And this is the life cycle and all. I'm not going to go. Dengue, 4 types are there. Again, one common question your relatives and friends might ask. எனக்கு ஒரு வாட்டி dengue வந்துருச்சுனா திரும்ப வருமா? Yes, you will get, because there are 4 variants, 4 types of dengue virus. Always one type, the cross antibody will not be there for dengue virus. So always secondary dengue is quite common, and primary infection, it is going to invade as usual your monocyte, macrophage, dendritic cells, and it is going to produce all the immune responses whatever has been given, and the final is your fever, myalgia and arthralgia. Okay, and treatment. See, important thing in this slide you need to remember is, see this picture. The first 2 to 7 days is called as febrile phase. Okay, febrile phase la what is going to happen? Dehydration is going to happen. Your hematocrit is going to raise, and the viremia is going to develop. The second stage is called as critical phase, where there is no fever, and that is going to be like 5th to 8th day, where shock is going to happen, bleeding is going to happen, organ impairment is going to happen. This is called as the critical phase of dengue. So 5 to 7 days, you need to intensively monitor if you suspect a dengue fever. And final phase is called as the recovery phase. And more than this phase, all the fluids which is like extravasated into the third space is going to reabsorb. Okay, so reabsorption of the fluid, platelets is going to raise, and your IgM is going to be positive only after 5th day of illness. Okay, so if you wrongly order IgM dengue test on day 1 to day 5, it might be false negative. Remember, if you order only after day 5 of fever for dengue IgM, it will be positive, true positive, right? I was talking to you about the critical phase where the plasma leakage is going to happen. So start IV fluids 5 to 7 ml per kg. If there is shock, you follow the shock protocol 10 to 20 ml per kg bolus. And in the recovery phase, all the fluid is going to get reabsorbed, and the hematocrit normalization is going to occur, and the urine output is going to be more than 0.5 ml per hour. So is there a dengue vaccination? Yes. So till now it is under phase 3 trial. Okay. So recommended only for individuals where they are getting previously infected with dengue. And maybe in future, like our COVID vaccine, it is going to come. So these are all research purpose. So one word I want to tell about the infections during MBBS internship. So please remember this. Interns are also watching this. So bloodborne, you call it as hepatitis B or C or HIV, needle stick injuries, contact with body fluids. Respiratory, again, wear a mask. Tuberculosis, influenza, COVID-19, because all are aerosol exposed. Fungal, quite rare unless you are an immunocompromised, taking some steroids, long-term steroids or chemotherapeutic drugs. Others, quite common, skin infection, salmonella infection, which is going to cause your gastrointestinal infections, right? Again, long working hours, it is going to cause fatigue, lapses in hygiene, improper hand hygiene, inadequate use of PPEs like your gloves, okay, personal protective equipments, exposure to sharps and body fluids, and lack of vaccination. So many people, you don't like take care of ourselves because of the time management, right? So prevention, please ensure that hepatitis 3 vaccine has been put. Up to date TD vaccine. If you feel like your finger is cut with glass piece while breaking a ampule or vial, influenza vaccine yearly, and post exposure prophylaxis if it is going to be needle stick injury. Okay, so dispose of sharps in designated containers. Please don't try to recap the needle after putting the injection. Disinfect surface and equipment regularly and maintain aseptic precautions. So summary and take home points of this interns, infection of the interns: hand hygiene, PPE, vaccination, and using the sharps are very, very key important practices. A safe intern is an effective clinician. Please remember this. A safe intern is an effective clinician. Okay, fine. So that comes to an end of my session. I think I maintain my time limit. Yes. So can we have some questions or
Yes, sir.
anything to be clarified?
Uh, guys,
Not
if
in
you have
India,
any
yes.
doubts, yeah, sir, guys, if you have any doubts, please put it in chat box.
Vaccines வந்து still now it's under phase 3 only. Phase 4 வந்தாதான் it will be available in our settings. No doubts. அதுக்குள்ளே thank you போட்டீங்க. I am ready to answer your questions. Can we get the slide? I will make it as PDF and send. Okay. Because this approach you will not see in any textbook, even foreign or Indian. This is like reference from multiple sources. It has taken a lot of effort to prepare this. Though it is a small topic, the content is very, very nutshell. So I'll share as a PDF. Okay, fine. If there are no doubts, I will hand over to Bala Hariharan. And two important things, as I have already told, please, I request the participants to fill the feedback form and as well as please attempt the quiz, right? So I'll just share. Sir, supposing a person presents with fever, headache, and retroorbital pain, joint pain alone, how to differentiate? Yes, this could be a simple viral fever. This could be a dengue fever, or it could be even a leptospirosis with all the features whatever you have mentioned. Okay. So again, it's going to be a syndromic approach. How to differentiate between dengue and chikungunya? Dengue and chikungunya is going to be multiple joint pain with arthritis. You will have swelling, you will have pain in the joint. Whereas in dengue fever, you will not have swelling and swelling in the joints. You might have joint pain, but swelling will not be there unless it is going to be a post-viral arthritis. Dark colored urine. Whatever you have discussed, everything can have dark colored urine. That is your leptospirosis, scrub typhus, dengue, malaria, cerebral malaria. Disabling pain. What do you mean by that disabling pain? Please post it again. Disabling pain. I couldn't get you. Is it possible to test and detect in the incubation period itself for certain diseases, especially in travelers? It's quite difficult. Okay. If that is why we tend to do all the HIV antibody test 0 day, 1 month day, 6 month. Because if you are in incubation period, it's very difficult to identify. So better take chemo prophylaxis for those diseases. So I'll just can I share the link? Dengue and meningococcal. Okay, dengue will be whatever we have discussed, that retroorbital pain with rashes, with breakbone fever. Meningococcal, severe sepsis is going to happen, and the patient is going to have rashes all over the body, and the patient will be in coma. Yes, if we don't have anything, please give tips for pre-final university exam. That is not my topic of subject. So I'm very sorry.
Sir, sir, am I audible,
Yes.
sir? Yes,
Yeah,
sir.
yeah.
Yes, sir. Sir, it's amazing session from you, sir. We learned a lot on the case presentation. That part is very amazing, sir. So, sir, can you please share the link in the chat box itself, sir?
I have shared in the group. Can you able
Oh,
to see?
yes, sir. Yes, sir. I am able to see, sir.
Two things are there. One is feedback form, and the other is a quiz. After attending this session, like, will you be able to manage these kind of cases? For that, I have made a simple quiz of only 10 questions. That will be very useful.
Oh, okay, sir.
And there is one more thing to announce. We have this quiz winners for the tropical medicine quiz, which was conducted previously. Can I share, Bala?
Yes, sir. You can, sir.
Okay, so congratulations for winning first, second, and third prizes in the quiz, which was conducted by our team. And the winners are first place Karthikeyan AG, Roshni S from MMC. Second is Arya Ganesh, AB Wims, and Dr. RMLH, New Delhi. Third is Shreya P. Shreya Kaushika from Sri Muthukuran Medical College. Okay. So congratulations to all the three teams.
Thank you, sir.
So is there anything else? Bala Hariharan.
Sir, some of them are asking some doubts, sir.
Yeah. Sir, this possible to test and detect incubation, I have answered. Night sweats. Night sweats is not like a typical fever. It will be more in hematological malignancy rather than this kind of fever you can have in malaria. Okay. Malaria is one important tropical condition where you have night sweats. But otherwise, night sweats is one important sign of hematological malignancy. After how many days we can start in syndromic approach? Usually it is 3 to 4 days. Okay. After 4 days only, you will be having all kinds of blood investigations that has to be done. Any guidelines for admitting the patients, need for observation and things not miss out in OPD settings. See, when people coming in OPD basis, it's quite difficult to analyze in what day and which day of presentation they are coming, because they'll be in a hurry to answer all your questions. Sometimes they may tell it is third day, sometimes they may tell it is fifth day. So always please make sure that history is most important part for diagnosing fever of unknown. I think I've answered all the questions till now.
Yes, sir. Thank you, sir.
Yeah.
I would like to hand over to Sanjana.
Thank you, sir. That was an amazing session and very informative. Now I hand over to Pedashri, IMA-MSN MMC Joint Secretary.
A very good evening to everyone present here. On behalf of IMA-MSN MMC, I take this opportunity to express our heartfelt gratitude to all the dignitaries and participants who made today's webinar, Winter is Coming, Approach to Common Tropical Infections, a great success. First and foremost, our sincere thanks to our esteemed speaker, Dr. Yogesh sir, for sharing his valuable insights and clinical wisdom with us. Your practical approach and clarity on tropical infection has truly enriched our understanding. We thank the respective IMA leaders, IMA-MSN and IMA-JDN Tamil Nadu Council of 2025 for providing this wonderful platform for learning and collaboration among medical students and young doctors. Last but not the least, heartfelt thanks to all the participants who joined us this evening and made this event interactive and meaningful. Thank you.
Sir, shall we wind up the session, sir?
Yeah, sure, ma.
Yes, sir.
Thank
Thank
you
you
all.
for.
Thank you, team IMA, JDN, MSN, who are all participated in this webinar. So thank you, Bala, Gokul, whoever, so the team. Okay.
Yes, sir.